Hey, good morning. Welcome to the Board of Health meeting. We're glad to see you all. So the first item of business is the minutes. May I have a motion for approval?
So moved.
Okay, Ray has approved and Joe has supported. Any discussion? All those in favor?
Aye.
Aye.
Opposed? Motion carried. So on the vouchers, Lisa, I didn't see any of your little boxes. Is there anything?
There's a
I
couple
know
of
you've
little,
been,
there's a couple little boxes.
oh, maybe I missed them.
So on, I think it's the second page, second voucher detail page. There's a charge for 11,000 from 4 Imprint. Though that's all Hepe, hand sanitizing, those kinds of items for it's running through our Hepe grant. That was probably the most significant. You can see some vaccination purchases there. Those are the larger ones. And other than that, everything else is pretty normal and not significant.
All right, may I have a motion for approval of the vouchers?
So moved.
Second.
Okay, so Vanessa moved and second was
Ken.
Ken, okay, sorry. All right, any discussion? All those in favor?
Aye.
Aye.
Opposed? Motion carried. One resolution.
Yeah, it's an unusual month that we only have one resolution,
Thank you.
but this is to enter into or really continue a office lease arrangement that we have had for a number of years with the Sickle Cell Disease Association of America. We have had a representative from Sickle Cell who's had a small amount of office space at Cubicle in our department, and we've had an agreement in place since 2014 to this effect. That agreement officially ended, I think, last fall. So Sickle Cell Association was looking to just reconfirm that agreement. We charge $750 for a year. So the terms of this agreement would be the period of October 1 to September 30th of 2021. We provide simply the space, and they provide all of the appropriate computer connections, all of those things. And we have found this to be just a valuable partnership so that the case manager from Sickle Cell can more effectively serve the residents of Berrien County by having some local space here.
That's great.
All right, any discussion of the resolution? May I have a motion for its approval?
So moved.
So Ken moved, and is there a support?
Support. Vanessa.
Okay, Vanessa support, okay. Any discussion? All those in favor?
Aye.
Opposed? All right, motion carried. We have a retirement. So,
Yeah, and if I may, we have a couple of supervisors that were going to be joining us and they haven't joined us yet. So if it's the pleasure of the board, perhaps we can move that a little bit further down the agenda.
with pleasure.
Thank you.
Okay, so we'll get into that chunky budget there, Lisa, with a cover.
Okay, I'm gonna kind of go through July's statements first, and then sort of we'll lead into the budget from there. So get July out of the way. So in your board packet, there was on page 3, our standard financial revenue and expenditure statement. So I'll just run through a couple of numbers there. Through July, state and federal grant revenues are favorable to budget by a combined total of 112,000, which is almost 5%. a good chunk of that is the $108,500 we've received so far for COVID. So COVID, especially beginning in July, is starting to have a pretty significant impact on our financials. We're also favorable to last year by 174,000, which is almost 8%. Some of the favorable to last year includes some additional funding that we've discussed in prior months for amendments to our comprehensive agreement. Other revenue items, again, I'm going to kind of reiterate the same items that we've talked about in prior months. Permits and inspections are over budget. That's a timing. A lot of that revenue comes in earlier in the year. The better metric to look at, or the benchmark to look at, is last year. And we're just slightly under last year by almost 10,000. So actually we're doing better there than I expected. But by the time we get to year end, we still may lag budget there a bit. There's some temporary and seasonal licensing that I don't think is going to come through, food service licensing that I think is due to COVID is not going to happen this year. So I'm still projecting an overall decline in those revenues, probably a little aggressively, of about 35,000 as far as our projections go. Medicaid, Medicare, private insurance, so basically our clinic revenues are under budget by 74,000, and we're also, which the budget I think was pretty aggressive. COVID, we closed the clinic in March, so we're definitely seeing that effect, especially in comparison to last year. So last year, we're under last year's revenues for the clinic by 26,000. I'm expecting that loss to be probably permanent for the year. I'm projecting an overall decline to budget of about 50,000 through the year. So also Medicaid Title 19 cost reimbursements. I think we will end up exceeding budget this year, but it's a quarterly payment. So I want to kind of reserve judgment on how well we do on that line item till we get closer to the end of the year. On the expenditure side, so the subtotal for direct expenditures, we can see that we're better than budget by 333,000. That's about 9% under budget. We're over last year. You'll see on the statement it says that we're under last year by 313,000, but last year includes expenditures for a medical examiner, and also there's water filter purchases on the supply line in last year. So if I adjust those out of last year's numbers, we're actually slightly over last year's expenditures at this point in the year, about 51,000. On the couple items on the salary and wages line, we are under budget 258, about 8% under budget. We're over last year about 151,000, so about 5% over last year's actual. Our fringe rate continues to run about 48%. It was 45 last year, so we can see the effect of a rise, especially related to retirement benefits. And our budgeted fringe rate was 51%. So again, I'm expecting to see some savings on that line by the time we get to the end of the year. What's going to really start coming into play from this point kind of forward, we've hired staff to do contact tracing and case investigation. Those hires happened in pretty much in the June-July timeframe. So we'll see the financial effect of those as we get farther along in the year. Speaking of COVID, so COVID-related direct expenses, primarily hitting the salaries line and fringe line, where we've used pretty much entirely internal staff to cover the COVID-related direct expenses. They took through July, they total 405,000. And as of yesterday, when I ran numbers, we've incurred about 506,000 so far this year. It's existing staff primarily at this point in our reporting. So we've redirected admin staff and program staff to basically handle the COVID response. We have some temp employees that are coming into play in the June and July timeframe. So the bottom line for the July statement is we can see that revenues are exceeding expenses by 298,000, which is a significant improvement over budget. That's the 606,000. Again, COVID is affecting our budgets everywhere. I think some of the revenue surplus will be eaten up as the staff comes in, as the hiring comes in to support the case investigation and COVID-related response. So, any questions on July? All right, so moving into budget, and hopefully I do this right. Yes, Nikki? Yep, okay. So turning to the 2021 budget, your packet includes statements supporting the budget on most of our financials. The comparatives are difficult, but anyway, so this year I've put together the packet beginning with basically a letter to the commissioners. So that's how I've introduced sort of an executive summary letter to the commissioners for your review, a draft of that letter, and then a number of supporting schedules. So Nikki, going forward, Nikki will kick us off, and then I'll join in again when we get to the numbers section of the budget.
Yeah, thanks, Lisa. So, I mean, we find it very important. I mean, the financials can't be looked at in isolation because the financials are there as a resource to make sure that we're serving our residents of Berrien County. So we really have approached our budget and always try to look at our financials in terms of what is the work we're actually trying to do so that we're using the resources to drive the work, not necessarily selecting work based on resources. Obviously, there's some bidirectionality there. But just as a reminder, I know you all have seen this many times, but the vision of the Berrien County Health Department is to have a county that's strategically focused on improving health outcomes and the elimination of health inequities. This has been our vision for a few years now. It's more timely now than ever. Our mission is really to prevent disease, protect health, and promote an optimal quality of life for all, in really understanding how there are a lot of upstream determinants that really impact health. We've seen a lot of that play out with COVID as well, or just be demonstrated throughout this pandemic. And then as an organization, we've gone through processes with staff to determine our values, and our values are really perseverance, being data-driven, being inclusive and community-focused, really focusing on empowerment and collaboration, because public health is not something that we, the Berrien County Health Department, can own, but we absolutely want to be the leaders for that, as there are so many partners that we're working to drive in this direction to achieve that mission and our vision. Next slide. So we've broken down a little bit, and again, I know you all are familiar with this, but it's always good to just have a reminder of this. We've sort of broken down some of our functions into 5 buckets here, if you will. The first bucket is really healthy families. We do a lot of work around assuring that families have access to the resources they need to be able to set them off and set young children off on a trajectory that helps them achieve their optimal health. So we have the WIC program, we have our home visiting programs like MyApp and NFP. We have parenting support like Triple P, as well as breastfeeding counseling. And then we also have our healthy communities bucket. We do work around food access, emergency preparedness, health equity, substance use disorder prevention, as well as Be Healthy Berrien, which is food access and physical activity access as well. So we've got a lot of functions sort of in that. With clinical health services, we provide a lot of in-house clinical health services for sexual health, including STDs, HIV, family planning, immunizations, tuberculosis control, and breast and cervical cancer prevention. And then we also have our community health services where we do infectious disease control. And boy, we're really seeing that with COVID, right? COVID spans many of these functions, but we do a lot of similar activities with case investigation and control measures for many other infectious diseases always. That's some of what we do on just a daily basis. We also have the Children's Special Health Care Services. We help people gain access to health insurance. We work with schools, and we also do hearing and vision screenings, again, to put some of those things in place to set children off and have people have better access to what they need for good health. And then we also have our environmental health services bucket, which depends a lot on doing food safety and protection of our food system, so consumers can be assured that when they are interacting with any of our many restaurants, that they can just take for granted that that's going to be a safe experience for them. We do a lot of work with private water, septic systems. There's some non-residential and commercial regulations, so a little bit around rental properties, maybe public health nuisance, those sorts of things, as well as recreational water and assuring that water is safe for people to recreate in. So we, as again, I know you know and appreciate, we have such a breadth of services and really a wide variety of things that we are doing. What 2020 has also just shown us with our COVID response is really that COVID does span all of these buckets. There is a place in which all of these parts of our functional structure are impacted by big public health issues, and they're really interconnected. So even though there's a lot of diversity here, there's a lot of interconnectedness, which is why it's really important for us. And we have to look at our budget and our resources from a very holistic manner and how they are intertwined with one another, sometimes from the funder, sometimes on our end, we know the functions are intertwined. So then how can we perhaps braid some resources together? So Lisa, we'll go to the next slide. I'm not going to read this to you in a lot of detail, but just wanted to point out some 2021 public health strategy priorities and some critical opportunities. And some of these are repeats. I mean, we've seen a lot of these have been on our radar. Emerging threats definitely come up, but there is a lot of, there's not a ton of change from year to year as it takes a while to tackle some of these. So the biggest one is definitely COVID-19 response. We know that this is going to outlast 2020. We're going to continue to have a really important role as a health department into 2021 with COVID-19 response. And we expect that next year we will be participating in mass vaccination clinics and in working to distribute that out. And there will be case investigation and contact tracing and coordinating with community partners. A lot of those activities will continue definitely through next year. And COVID-19 is not the only emerging health priority. I mean, last year we saw a lot with Triple E. We're not seeing that so much right now, but there's always something that has the possibility to creep up. PFAS has been a big thing around the state, vector-borne illnesses. So there's a lot of those emerging public health issues, and we always ensure that we're poised to be able to respond to those. Also, increasing access to health services just remains important. I would argue that there may not be quite enough services to serve as everyone who needs it, but there's room for increased access to those things. This is reflected in our programming, but it's areas that we can grow as there's opportunity to do so. Ensuring a healthy community, providing health and nutrition education. These are things that we have been really involved with and will continue. And again, supporting healthy babies and outcomes for children. Supporting families and children right now is also incredibly important, just given some of the unintended consequences or the collateral damage that has come from some of the interventions of COVID-19. We know that families' economic situations have been disrupted. School has been disrupted. So many things about life has been disrupted. And in those early years for young families and young children, that can really affect the trajectory of somebody's life course in terms of health. And so really the work that we do around family health right now is becoming more important than ever, as we don't want to compound the impacts of COVID-19. So these are some of the things that are on our mind and where we're really trying to look. Again, 2020 has shown us that nothing is really truly predictable, and something can really come out of the woodwork and require attention. I'm very proud of how our department has been able to really maintain a focus on the things the day-to-day things that we need to keep going because they're really important, while also dividing some of that attention towards an emerging threat. And we continue to have ourselves poised that way. And we believe that we've set up the budget that, given what we know today, has us best poised, given the resource limitations we live in as a local health department, to help us meet these challenges to the best of our capability. So I think I'm going to pass it back to Lisa at this point.
All right. So, and to kind of go forward from there, putting this year's budget together was a little bit messier than usual. COVID sort of is filtered in everywhere. And always for us, sort of year-to-year comparisons are difficult, just because are we comparing this year, the 2021 budget, to a 2020 budget that was prepared in August of 2019. So the timing in all of those sort of comps gets really difficult to kind of make any sense out of. So our approach, COVID or not, is always sort of a zero-based budgeting effect. So we start with the revenues and the programs that we are expecting, and we have commitment to and revenues awards. So we have commitment from our funders to proceed with those. So that said, looking at our numbers, the overall outside revenue, so everything except for local appropriation dollars, is looking at a state and federal funding increase of 5% over 2020 projections. So they're budgeted to increase to 5.1 million from 5.1 million in 2020 to 6 million in 2021. That's an $866,000 increase and a $264,000 increase over 2020 projections. Remember, the 2020 projections now include a hunk of COVID dollars that are coming into the 2020 actuals. COVID funding for next year is budgeted at $940,556. 2020 currently includes $645,760. So the COVID increase year over year is about $295,000 increased in revenue. So the combined of the 2 years of COVID funding is 1.7 million so far that's been released to us. We assume for next year that permits, inspections, licensing would remain flat year over year, budget to budget. Client fees, Medicare, Medicaid in next year's budget total 192,000. It's down about 13%, 28,000 from 2019 levels. So I looked at 2019 as a comparative and budgeted a little bit of a decline from there. I'm not sure how much of an impact COVID's going to have on next year's clinic fees. Medicare Title 19 cost reimbursements, I'm showing a decrease of 37, almost 38,000. It's in line with, so we report following the end of a calendar year. So we've just recently done our 2019 reporting. I use that reporting to base our revenues on for 2021. Other sources included revenues from our 4x4 grant, which are mostly a pass-through. Quite a bit of that grant is contracted out. And also I've included farmers market revenues that we haven't reflected in the past. Again, that ends up being a revenue item and an offsetting pass-through to the farmers. On the expense side, again, following along with our budget-based theme, we developed the expense side of our budget. It's driven by our programs and services. A good portion of that budget, about 80% of that budget, is related to staffing. So every year we go through, we look at what our programming looks like for the next year, and basically develop our staffing budget from there. So budgeted staffing levels are increasing to 80.75 FTEs from 72.75 FTEs. We've added 9 full-time positions for COVID-19 response activities. As I've said, they're focused on contact tracing and case investigation. There's some added communications, costs for outreach to county residents, and we're special project coordinators, which will also help with our communications with businesses and school coordination. Included in your packets on page 9 is a listing of our FTEs by position. 2021 budgeted salaries and benefits total $6.4 million. It's an increase of $903,000 over 2020 budgeted levels. $593,000 on the salary line, and a $310,000 increase in benefits. COVID-related staffing accounted for $653,000 of that increase. The budgeted benefit rate remains at 51% for the 2021 budget. But a little bit higher than what we're seeing on the actual side for 2020 so far. That actual rate has been running about 48%. Non-payroll related expenses. So sometimes they're not necessarily discretionary expenses. Our programming will determine some of how we're performing or how we're accomplishing those programs. So our expenses are generally program driven. They're budgeted for 2021 at $1.1 million. It's about a 6% increase over 2020's budget, which is about $67,000. Communications and outreach related costs are expected to increase $24,000. We're also seeing an increase on the contract line due to pass-through contracts for as I've said, the 4x4 health and wellness grant that were not included in last year's budget. The big change on the expenditure side is the decrease that we're seeing in the county cost allocation for county administrative costs and costs related to our facilities. It's a decrease of $434,000, which is a 28% decrease. the 2021 budget that we pulled together also, per guidance from the county, assumes that our appropriation will remain flat. So at the end of the day, putting all those pieces together, we expect to have a fund balance use of about 197,000.
Why'd the county allocation go down so far?
It's determined by an outside firm. A firm called Maximus comes in, and each component of the allocation is kind of it's got different. It's based on different things. Like HR is distributed based on the number of employees we have. IS, a big piece of that, is distributed based on the number of computers we have. Our facilities cost looks at square footage of this building versus the conference center, and there's an allocation there. So Maximus comes in and annually, after we finish each year's audit, and redetermines what that allocation is. The numbers that we're seeing this year lag. So this year is allocation is based on 2018. It's a 2018 actuals, and there's a roll forward piece of that. So they do an estimate based on a prior year. When we get through that year, they go back and compare that to the actuals and keep rolling that forward. So I did go through a pretty heavy review with county financial services to make sure that the allocations that we're receiving are proper, that there's the right number of phones included in the allocation, employees, square footage, and so on. So I do think that our numbers are also starting to trend down, because I think there were some costs, especially related to earlier years, related to the build out of this space and kind of right sizing expenses related to the new facility. So I'm hoping that we're now going to see kind of a leveling off and hopefully some consistency year to year, because you'll see in later slides how the variance in that number really affects how we budget and what our use of fund balance is, and how we kind of attempt to sort of manage the ups and downs there. Okay. So
How much fund balance is left after that deduction?
it's year to year. Hang on, I do have a slide that talks about fund balance.
Okay.
So after all is said and done, this slide gives sort of a historical perspective of where we've been, fund balance. And you can see there's pretty huge swings in those numbers. We attempt to, and I think sort of the appropriate amount should be between 700 and 800,000. That would allow us on a year-to-year basis to sort of manage the swings. It's kind of it's steering that boat. So we looked at 2019, ended up with a surplus more than we expected in our fund balance. 2020's budget took care of some of that. I think we're going to do a little bit better than that's in the 2020B column, the 807,000. I think with COVID coming in, which it is helping to offset some of our overhead costs, our administrative overhead costs, I think we're going to end up a little bit better to budget by the end of this year. And so I'm projecting that fund balance, and this is the unrestricted fund balance, to end the year about 1,031,000, and then into 2021's budget, we're again we will dip into the fund balance again and bring it down to about 834,000.
Thank you.
Okay. So this next slide, I'm trying to illustrate and I draw attention to where we've come with our revenues over the years. So it just to provide a little historical context, we've increased our government grant funding from 3.8 million, almost 3.8 million in 2015 to 5.2 million budgeted for next year. That's a $1.4 million increase in dollars that the health department is bringing into Berrien County, all dedicated to public health. The external sources of revenue account for about 70 to 72% of our budget. So for every dollar of county appropriation, we're able to generate about $2.50 from other sources. So I'm trying to equate a return on that investment, and also to show that there's a concerted effort on the health department's side to bring in year to year to year more and more revenue, pursue more and more grants that fit our mission. Any questions or comments? We're doing great, right? Okay, so 2021 proposed programming. Of course, COVID's going to be a big part of what we do next year. It basically equates to about 16% of our operations this year and into next year. But I also wanted to show that ongoing activities continue. So you're going to notice immediately that environmental health, healthy families, and even healthy communities are showing a decrease in expenses. That's directly affected by the reduction in indirect costs that are coming from the county, and also as a result of us shifting some of our administrative costs into COVID-related response activities.
Hey, Lisa, could I ask a question on environmental health? It seems like there's been such a spike in building, but that's not, so our services are not increasing because of building for septic and things. You don't see
No,
that?
we haven't. A big part of environmental health is staffing, and we have not added any staffing. No, the FTE count is consistent with year to year. So we've dramatically affected our indirect cost rate. So for this year, for 2020, our indirect cost rate was almost 51% or 50.8%. We're reducing that indirect cost to a 36.5%. So that, and especially in a segment of our for environmental health, which is very staffing centric, and because indirect costs are an allocation based on staffing and benefits, our overall personnel costs, you can see an immediate effect of that reduction in indirect cost rates.
And if I can just jump in for a second, Peg, to your point, yes, we are seeing an increased demand for septic installations and those sorts of things. We did see after the shutdown, there was a lot of pent up demand from the spring, and it has been a very busy summer for our team. So we are seeing that. We're managing it right now with the amount of personnel that we do have. They're busy, but we're getting through the workload.
Peg, could I ask a question?
Please.
Lisa, throughout this, has there been any attempt to quantify the time and expense of normal staff that has been shifted to COVID during this period of time? That's the hidden expense here that I don't know if we can show anything on that.
Well, we are definitely tracking that, Bill. And the way that we do timesheets at the health department, we've actually asked staff to code time that they're spending on COVID responses directly to that program. So we do have the ability to track staff time against COVID. There's kind of a ripple effect. So it's, if I can speak to myself, everything that I do probably has a piece of COVID related to it these days, but I'm not necessarily charging all of my time there. It's mixed in with how I put together a financial or how we're processing timesheets, procurement. So it maybe isn't an exact science. There's still some kind of more overhead costs that are associated with COVID that we may not be tracking specifically to COVID. But for the most part, I think we are capturing a majority, especially our program related staff, for our contact tracing efforts and our case investigation. Those costs are definitely being tracked.
Well,
So-
and can I add the other side of that though is we do have a lot of the response burden has also been on salaried individuals. So while salaried individuals are charging appropriate time to those COVID-19 cost centers, when you're salaried, it's just for a portion of your time. So if COVID resulted in an extra 30 hours in a given week, which it has been commonly doing over the last 50 or 5 months for many of our salaried folks, that's still only going to count as half of their time went to COVID, as opposed to really showing that there was an extra 30 hours of effort or whatever that might be. So for any actual true additional costs due to overtime and comp time and some of that effort, it's definitely reflected. But with some of our salaried individuals, it's tricky to really quantify without going back through individual timesheets.
Well, and I think you've answered, but I think the commission needs to hear about this hidden stuff. Not that you haven't tracked it, but it's assumed in your job. I mean, Nikki, you still have everything else you had to do pre-COVID, and now you're doing COVID 30 hours a week. How do we articulate for the commission in the budget process that new burden that has been there for the last 5 months and is likely to continue for another 12?
Yeah, that's a great point, and we'll try to figure out how we can frame that to make that more clear. Thank you.
Great, thank you.
And make a real quick comment. I
Absolutely.
think, Lisa, maybe you underplayed this a little bit, because I don't know if you were around back whenever we had some quite big discussions about the direct overhead, but this, the reduction in it, how does that impact, or how do we look at it as far as maybe more efficiency in some of the programs we're dealing with, or just overall operation of the department, going from 50% to whatever, 51% to 36%, and how in the past we argued internally about how that was impacting our ability to win grants. And is that something we're going back, and I'm sure we are, renewing that, rethinking that as we look at new grants, or re-upping on the grants that we're dealing with?
That's exactly right, Ray. I mean, it affects every grant that we work with. So, and I think that the rates that we're at now are more reflective of market rates, actually. So if I break down our rate, 8 of the 36.5% that we're looking at for 2021, it's 8.5 of it is related to what we call space costs. It's facilities costs, it's maintenance of the building and utilities, depreciation is in there. About 8.5 of that is county administrative allocation. So for us, the county does HR and payroll, audit costs, IS and all of those related support services that the county provides for us. And then about 19, almost 20% is the allocation of health department admin. So me and Nikki and Courtney, any of our time that's not specifically charged against a particular program is pooled and spread across all of our grants. So I am looking at these numbers and going forward, I think we're much closer to a kind of competitive number with the market. So when the federal government puts out grants, they pretty much limit it. It's a modified calculation, admin to 10%. They only include like the corner office, basically. Those are administrative costs. We lump everything into one rate. So we have a 36% rate that includes costs that, from a federal point of view, is not exactly administrative. So on some of our grants, they limit us to a certain percentage that the grant will pay for. And the gap there, we then use county dollars to cover that gap.
So I'll add to that too, because I think I heard a little bit in your question, Ray, just, are we trending in a direction that maybe some of our grant acquisition concerns we've had in the past are lessened? And Lisa's got a slide coming up that'll show there's just a lot of variability in what the county services allocation actually is. So this is a pretty big swing down compared to what we've seen. But there have been a lot of swings, and it does make it challenging to plan because we don't know exactly what it'll look like next year until we get next year's Maximus report. So that is a bit of a challenge, but it gives us maybe a little bit of hope and some optimism. Lisa sort of, said this, but I guess I'll say it a little bit more directly. As we were, Lisa spent a lot of time with County Financial Services going through that Maximus report, making sure that all of the costs that were allocated to us were appropriately allocated. And there had been some misattributed costs that were allocated to the health department that shouldn't have been and have been in years past. So now that has been rectified, it's possible that we may continue to see this might be more of our normal rate going forward, but we'll have to see. There's a lot of variability there.
Understand. Good. Thanks, guys. Thanks. Very good. Much. I appreciate it. Good.
So again, not to kind of belabor the point, expenditures are increasing 537,000. But what I did want to point out is that the health department admin is less than a 1% increase. A majority on the salary and benefit line, a majority of the increase you can see is operations and programs, and again, relates back to the added effort related to our COVID response. Okay, so this kind of, hopefully, Ray, this chart will give us a little bit of an idea of the interplay of some of our revenues and costs. So the top basically shows a nice and healthy increase in our year-to-year appropriations. The trend is up, as you can see, it dips up and down as we go along. Beginning in 2012, our allocations, we began to get an allocation of county services. So the challenge from a budgeting standpoint is to balance our net funds after appropriation less county services allocation. We have what that net funds for operations is. And you can see that those are pretty dramatic swings year to year. And basically what we've seen since about 2017, the appropriations or the allocation amount jumped higher then, and we're starting to narrow in on the appropriation. In other words, there's a slight increase in the trend line, the red trend line, as compared to the black trend line for the appropriation. So there's a little bit of a squeeze happening there with how much funds are left for our operations at the end of the day. So our budget looks at a relatively short time frame. But what these swings create is a really difficult time for us to do a longer term forecast. So it especially related, so we use our fund balance to kind of smooth out the ups and downs that you're seeing there. So we also included, this is in your packet too, so probably more history than you want, but I'm kind of a freak when it comes to history. But so you could see the county appropriation increasing year to year to year, steadily rising. Medical examiner kicks in the 2014. Again, that's now paid out of the general fund directly on the county side, beginning this year. So, and then you can see the swings in the allocation, our allocation. So beginning in 2012, I think we're beginning in 2012, 2013, we begin to see the build out of this building and the effect that's having on our county allocation. Our 2020 budget included an allocation of 1.5 million. So the percentages I have there is, after all that is said and done, what percentage of county appropriation, less the medical examiner and county services, is left for operations? So I ran percentages and the net operations funding to give an idea of how the size of those variances from year to year to year. So what we try to do when we go through the budget process is then sort of, it's a big puzzle. So we put our revenue together with, this year is a flat county appropriation. And it's a big puzzle, and then determine at the end of the day how much of an effect that's going to have on our fund balance. So the fund balance then becomes our kind of stopgap to fill the ups and the downs. To go from the 2019 net operations funding of the $1,030,000, a drop down to 821. We're looking at next year of net operations funding, now that we've gone from the 1.5 million of county services to the 1093. I think we're going to be able to fill some of the budgeted fund balance that we were budgeting to use this year. So to go from 1.3 to 806,000 use of our unrestricted balance, I think we'll do a little bit better. But again, looking at sort of consistently budgeting our 2021 back down to that same level of use of fund balance gets me to the 834. So it's I'm attempting to kind of try to illustrate the interaction of all of those moving parts. Any questions?
Lisa?
Yes.
I just want to say, I think that sort of summary in the first page, way back,
Yep.
was just really helpful. I mean, I think that's really those, sort of data points and talking points succinctly take us through what many of these pages say, which I think is helpful.
Well, and the health department really functions differently, I think, than any other department in the county, because we're so grant driven. We're not necessarily focused on year-to-year expenses and controlling those expenses. We really determine our budget based on the programming that we're expecting. We base our staff on that, our FTEs on that, and we react to it. We manage that as time goes along. So I hope I've gotten across that, you know, if I'm looking at an increase in expenses from 8.04 in 2020 to 8.57, that's not necessarily an increase in discretionary expenses. It's an increase in expenses driven by the programming that we're expecting in the next year. So again, we start with that zero base of programming and attempt to kind of interact all of the overhead pieces, benefit rates, and so on. So I'm trying to get that point across.
And you did. This is very well presented.
Very well. And I just want to say really well, I mean, I know this is an enormous amount of work.
Oh, thank you, Lynette.
And you're both trying to plan and be responsive to things that you may or may not know come up. And that's a difficult position to be in.
Well,
but, neither of us make widgets. So you know, we're looking at health, and we're looking at nutrition, and we're looking at emerging needs, and
Yep.
so yeah, no, very well done.
Mandates and everything, yeah.
Right.
Well,
Especially
Lisa, I think this was absolutely the best presentation that with you and Nikki since I've been on.
Yeah.
board. You did
Agreed.
a great job. I think it's going to be very helpful to the commissioners. It's been the clearest, most. So
Yep.
You did a great job.
Well, and I've
Every
had
year they get better.
Yeah, you do.
Good job.
well, and I've had some questions too, and I'm trying to focus a little bit on how we leverage the dollars that the county provides. So for every dollar that we're provided through our appropriation, we're also pulling in $2.50 worth of outside intergovernment and other grant sources revenues into the county, reinvesting them into our programs and services. So we do operate a little bit differently. 70% of our revenue is derived outside of those county dollars, and I'm hoping to really illustrate that point this year.
The thing I like, Lisa, is that you have things for every different learning style. So Linda likes to read it. I like to see the graphs, you know, and then some people are verbal. So you're hitting on all those. The only thing you don't have is smell.
Oh, dang. I gotta
Don't
figure
go,
that
don't
one
need to go
out.
there.
Burn some
To
incense.
add
as you're
on for
presenting.
Zoom.
Okay, one final thing. Final slide. We do and have submitted a capital improvements plan. I do not have the 142,000 reflected in our, that would come out of our fund balance at this point. So again, we requested Niles Clinic upgrades last year, and we're only approved for 15,000. We have not actually incurred that cost this year. And the exterior signage is also a repeat ask. It was not approved last year, and maybe even more important this year, given that we're expecting to move into a vaccination stage, and exterior signage and traffic flow is becoming a regular conversation. So
And if I could just add, so the Niles Clinic, it's not about not just redoing surfaces or remodeling. It really is about trying to reconfigure some of the space in the clinic area in Niles, because there are some family planning services that we are unable to offer people because there's not enough space in the exam room for the nurse practitioner to maneuver. So there's certain procedures that have to be done in the Benton Harbor office and can't be done in Niles. And that obviously is an issue for us.
And that concludes my presentation. Nikki, what's the next step with the budget?
Yeah, so the next steps are, we do have our budget hearing scheduled for 2 weeks from today, and that's where we will be presenting to the Board of Commissioners. Those will be all Zoom, so we're going to work to make sure that it's as engaging and succinct as possible while still telling this story. We do have plans to meet with Administrator Doucette as well, since this is his first budget cycle, and make sure that he is versed in and has an opportunity to make sure that any of the nuances of our budget that he might not be familiar with, that he has that opportunity. So we're working through those processes. So yeah, and I think that there's some other more technical things that the financial staff is working on to get the budget into Munis and those sorts of things, but we're working through that schedule. And then the commissioners have a whole process they work through for rolling everything together and figuring that out. So I assume by October, by our October Board of Health meeting, perhaps Commissioner Chickering will be able to give us that update as to where that roll up is.
Well, thank you so much. I know it was a team effort, but Lisa, you bore the brunt of it. So thank you so much.
Thank you, Becky.
Yeah, really well done.
Yeah, thank
All
you.
right, do you want to go back to Darcy, or shall we proceed on with the agenda?
You know what, I think it would be good to do that resolution now. I'm not sure that the supervisors were able to get on, but we can talk about Darcy and her service. Darcy is not able to join us today, so we will get the resolution approved, and we'll work to get signatures from you all somehow so that we can give that to her. But Darcy and Jillian, I'll tap you to speak as well. But so Darcy has been with the health department since 1991, and she has spent all of those years, those 29 years, serving our WIC clients. She has been a tremendous asset to that team. She shows a lot of compassion and understanding, and just a desire to be in service to that clientele, and we have so appreciated her efforts. You know, Jillian has spent some time overseeing the WIC program, and it can give us some more specifics. So Jillian, I'll turn it over to you.
Thank you. I have gotten to know Darcy pretty well over the last couple of years in my involvement managing WIC, and you know, she is just someone who has a lot of passion for families, for new moms, for new families with babies and young children, and that's evident in how she is able to interact with our clients. She has spent a lot of her time in our Niles office, but also has helped out over the years in our Three Oaks office as well. And over the last couple of years, made her way up to Benton Harbor more often with some of the clerk sharing more duties. So it's been a real pleasure to know her and to work with her, and we will miss her, but we wish her all the best in her retirement, and just a lot of happiness and healthiness and rest in her years to come.
Absolutely.
Oh, lovely. What a lovely tribute to Darcy. So give our thanks as well as the certificate. So
We will.
That's-
Thank you.
retiring like that is amazing. So,
Yeah.
all right. So we're moving on to administrative reports.
Yes, so we've changed up a little bit of how we formatted this on the agenda, a little bit more by topic as opposed to by individual. And so some of will be popping in and out, I guess, of each other's updates. So I'm going to start by sharing my screen. Make sure, whoops. All right. So you all can see my PowerPoint now?
Yes.
Yes.
Okay. So these are some of the slides that you've been seeing and others have been seeing quite frequently. But as you know, we look at many pieces of data and we're tracking where we're at. So this is our 7-day moving average of confirmed COVID cases amongst Berrien County residents. And this is the epi curve that dates back to our first case in late March. So you can see in the month since we last met, we had this peak in July. Again, that was pretty equal to the peak we had in May. We were starting to come down when we last met and weren't really sure how far down that would go, if we would get back down to those June low levels, or if it peaked back up or what happened. So really what has happened a lot for the month of August is that we've got that, I don't want to say flattening per se, but we've got some stabilization in the amount of transmission that's happening and the amount of new cases per day that we're seeing. We are mostly running between 10 and 14 cases per day as our average moving forward. The shape of this epi curve, the fact that we've got some ups and some downs and then some smaller ups and some smaller downs, this is pretty much to be expected. This is one way that a pandemic strain of a virus can run through a population. So we're going to continue to see these undulations as we move forward in the epi curve. We're not seeing the wildly dramatic upswings, so that's really good. And what we have been noticing pretty much since the end of June is that the majority or more cases, a larger proportion of cases compared to what we saw in the spring, are milder and asymptomatic. And that is a reflection of just increased amounts of testing that is happening in Berrien County. But we know that confirmed case count really, even though that's been a place that a lot of media attention has focused, it's really an incomplete picture. So if we look at the percent positivity, this is the percentage of COVID-19 tests that come back with a positive result. This is also taken in concert with some other data facts. This is a really good indicator of what's happening in a testament to, do we have enough testing to actually capture all of the cases? And so you can see our trends. Again, this goes back to March, but really what we're seeing is we've been hovering really between 2 and 4% since late June. We've had a slight excursion just above 4%, but we're really hovering right around 3%. The fact that there's stability in this number, that 3% is given as somewhat of a guideline that if you're at 3% or below, that you are adequately capturing what is really going on in the community. Back when we were here in April, we knew that there were lots of people who were probably ill that were not tested, never showed up in our case count. This is giving us confidence in our case count. Are we capturing 100% of cases? Absolutely not. We know there are people who are asymptomatic and maybe mild, they never seek that healthcare, but we're doing a phenomenal job. We've had some terrific partners that have contributed to the fact that we have this increased testing and adequate testing, and that has been incredibly important. So a huge thank you and appreciation to Spectrum Health Lakeland and Intercare. They have done so much testing. The Rite Aid in Bridgman and Niles continue to do testing as well. And we'll talk about this in a minute, but we do have some more test sites that are coming online soon. So lots of testing in Berrien County. Per capita, I think we're ranked maybe 3rd in the state for the amount of testing done for our residents. Really proud of that. That's an important thing for helping us slow transmission. So another piece of data that matters a lot is hospitalizations, because that again is something that can't be impacted by a testing strategy. If there are enough people that have become infected, that they become seriously ill and need to be hospitalized, there's no way that we could actually mask that. And so what we're seeing, this trend is, this epi curve is over the same trend as that first graph, and you'll see there was a little bit of that peak in hospitalizations in July, continued to into early August, and then in the last few weeks it has really been fairly low levels, and we've had days where there has been no new case admitted to the hospital. It's also worth noting that this graph is showing people who are in an inpatient bed with a COVID diagnosis, with a positive test. There are, because everybody who's going into the hospital is receiving a COVID test or being seen in the emergency room, it's likely, and we know there are cases where there are individuals who are hospitalized for something that's not COVID, but they are COVID positive. So all of these things taken together are really encouraging about what is going on in our community. And when we look at deaths, the deaths have really slowed this summer. Thankfully, we're not seeing the amount of premature deaths that we were in the spring. Some of this is a reflection of we're seeing younger people that are ill, and we know that death is less likely amongst the younger crowd. But again, we continue to be encouraged. All of this data is great in terms of school starting. So this is meeting the criteria, meeting the data metrics put forth by the state as to it being safe and appropriate for schools to open. And so I'm really pleased that that's where we're sitting here at the end of August. We know that things could change, but we're continuing to keep a close eye on things. Dr. J, are you there? Oh, there you are. Are you able to want to add to that? Oh, Dr. J, we can't hear you.
He's unmuted.
It looks like he might have just froze. Oh,
I can hear him talking through the wall.
That doesn't help us.
No, we can't hear. Okay. All right, so while I think he's gonna come maybe into my office or somewhere so that we can, he can get on here, but we're definitely seeing, like I said, encouraging trends with the data. I mentioned about testing. Oh, Dr. J, are you ready?
Sure, sorry, I don't know why my computer isn't doing it, but just a note about the July increase in hospitalizations. We made snapshots several times of that, and more than half of the 7 or 8 or 9 patients in the hospital were people that were admitted for getting an orthopedic procedure the next day, getting a kidney stone removed or whatever, who were positive but had absolutely no signs of COVID symptoms at all. So that number really doesn't help us very much, and is reassuring actually that it wasn't because of some new increase in the number of cases.
And can I just add for clarification to the board? So what sometimes does happen is that somebody has a positive test. There's a phenomenon where somebody might test positive well after their infectious period, up to 4 weeks after that time. So if
Correct.
somebody is hospitalized and has a positive test, but they are not experiencing COVID symptoms, they've got something else going on, it's possible they were infectious and sick a month ago, but were never tested and had that confirmed. And so we're seeing this later. So that is a phenomenon that's out there.
They were always a completely asymptomatic case.
Correct. Yep.
But,
Yeah.
but is it not possible that they are spreading it even though they are asymptomatic and they may be testing?
It is possible that they're spreading it, but those are not the big spreaders. The majority of the events that are happening are events that are people from, that have significant symptoms. Those are the spreaders, because there's so many asymptomatic people, and so there's so many more of them than symptomatic people that will be a source. But really, on an individual basis, someone who's sick with symptoms is much more likely to be spreading.
Yeah, there are a couple of things I'd like to say about sort of what's been going on at the hospital over the last month. Number one, just to be clear, the patients that are tested that are admitted at Lakeland are patients that are having procedures done. We've tested every patient that's had surgery since April, and it's amazing how we have had virtually no positive patients for elective surgery. Secondly, if you're admitted through the emergency room, you're going to have a procedure or you have symptoms. So not everybody's tested. Linda, your question is very interesting about this continued infectivity. If somebody has a positive test, the CDC a couple of weeks ago just published information stating that you really don't need to retest them, because some of the positive tests that we were getting at Lakeland were the result of repeated tests in patients that were well beyond the period of infectivity, which they estimate, Rick, I believe 10 to 12 days.
The vast majority of people are 8 days. So
I just wanted to clarify that.
Yeah. So the CDC keeps pushing back the number of days that people are allowed to have a positive test and thought not to be infectious. And now it's out to 3 months. The anticipation is within a week or two, they'll be moving it to 4 months. Where it's become a little problematic for us now is somebody who gets a test for one reason or another in a nursing home who was positive 3.5 months ago. Because of the CDC's new rule that you could only count it up to 3 months, they become, quote unquote, a new positive test, which then puts new burdens on the LTCU of rules they have to do, et cetera, even when pretty much everybody who really can think about the topic knows that this person who has no symptoms at all is not at all infectious. They just have to maintain positive test. We can even remember that poor guy on the cruise ship a million years ago, way back in February, who stayed positive for 107 days. So that's going to happen.
I have one more question, and that is, it appears that the demographics from an age standpoint are changing. Are the demographics from ethnicity changing? Are we seeing that? I mean, I know we're seeing younger people getting it, but are we seeing it move? I know we're seeing it in rural communities. So it is sort of the where it is and who it's infecting seems to be changing.
So it's a good question, but a lot of it depends on where the current spikes and peaks are. So it depends on, what state, what area, whatever, what the ethnicity relative rate is. But if you look at Florida, which has a higher African-American population, for instance, than Michigan does, it's been the same disproportionate effect on people of color, both Black and Hispanics. So both groups have had it more. When a state like Phoenix, which has a low Black population, is hit, I mean, it's a little harder to measure that actual difference.
I have a question also along the same line about the percentage of COVID-19 tests that are positive in communities, and if that is having an impact upon whether some communities are choosing to keep the schools closed or do remote learning only. I just wondered about that, or is that just something that they decide on their own?
That's a really good question. And that is what is supposed to be taken into account for the opening of schools in person in any given community. And the number that's often looked at is if you're below 3.5% or 4% positives, those are good numbers. And that's where, as Nikki pointed out, we have been, in terms of percent positivity. So that's one thing to look at. If you just look at the number of positive cases in a community, that is so dependent on how much testing is done there and by whom. For instance, if you have a migrant population that in the previous week has undergone significant testing, that is going to increase your percent positivity. So you have to look at things like that. Or did the National Guard come in and check your long-term care unit, which may or may not be having a problem? So those are going to be factors, yes.
Okay.
So that's also listed in the CDC's guide to physicians and to health departments and other providers. They are supposed to look at what was the transmission in your area in terms of how you view, whether you should open schools or how often you test and what discretion a physician uses in who they test. And that's supposed to be taken into account. The providers are given discretion when they're faced with a kid with a symptom. And if I can move on to schools a little bit, Nikki, I don't know if you want to move on to that. So what I've been stressing and talking to lots of providers is trying to focus really in on the big three. And that's what a lot of people are doing. The big three symptoms of fever, cough, and shortness of breath. Focus really in on those because those are the symptoms that, number one, they're the most likely to give you a positive yield in terms of a positive test. They're also most likely to give you an actual current positive infection and not somebody who's symptomatic from way in the past. And they're also, that's also the test that's more likely to tell you somebody who's actually going to be more likely to spread it, for instance, in a school. If you have a kid with a fever and a cough, that's a kid you want to get the heck out of there. And that's a kid you want to test and find out what they actually had. So that's a way we've been sort of, trying to work that with the schools. And Nikki asked the question the other day and Guy's working on it. So what's the background and what can we sort of tell schools about, what to expect? And we have to be able to explain to them that we expect that there will be background cases. There will be cases that are happening because of what's happening in the community. And that the majority of kids that are going to end up being positive, what they've seen in places like Florida that have been open for a couple of weeks from now, the majority of cases that are happening from community sources and from homes and not necessarily what's happening in the school. So what positive tests are going up, or even going up with somebody who's in the school may very well not reflect what's actually happening in that school that's doing a good job. The other thing is, we have to expect, just like we saw with long-term care units, it's going to be uneven in terms of what's happened. School A may be doing a better job than school B, but they may have more cases just because of what happened there. There was one student, one teacher, just the bad luck of a super spreader. That is going to happen. We have to expect that's going to happen. And so to me, the frustrating thing is there will be these unrealistic expectations that are going to happen, and we've got to try to counter that. There are going to be increased cases. When schools have opened up in the majority of communities, like in Florida, concomitantly with that has gone increased testing has happened at the same time. If you do increased testing, just as Ken pointed out, you are going to find more cases. And it may have absolutely nothing to do with what's going in the school. If you did that, if the school hadn't opened and you just did increased testing of school-age kids, you would find more cases. That's just a fact. So that has to be kept in mind.
And also, I've been hearing a lot about the fast COVID test that's supposed to be coming out. It's $5, I hear, and it gives you results in 30 minutes or something like that. Have you got any?
There are multiple tests which are coming out faster. And one of the big things that's coming out now that probably is going to hit a lot of providers is saliva tests, and also self-taken nasal tests, which a lot of providers and some of the walk-in clinics are going to be going to. So it'll be a little bit easier to get a test sooner and easier. So those are going to be happening.
Rick, I was wondering if you could comment on whether there's been any standardization within school districts. One question that I have is, if you're a kid in Niles and you're positive for COVID, does each school have a plan of how to deal with that situation? Or are we potentially going to have overreaction, everybody going to online education again, similar to what we saw, and it was understandable at the beginning of this crisis? Wonder if you could comment on that.
I'll let Nikki answer that one because she's been working more directly with that.
Yeah, so every school does have a plan, and the health department has plans for how we're working with schools. What ultimately, and this was actually in some wording into the return to learn bills that were passed by the state legislature and signed by the governor a couple of weeks ago, the schools retain the authority to determine how they're going to provide instruction. So while I, as health officer, have the public health code authority to close a school if it represents an imminent health threat or a public health hazard, the schools retain the authority to determine, are we going to be in person, or are we going to be virtual? So we have done a lot of work with our schools, definitely over the last month, but even back in July, of trying to run through what some of these different scenarios are and to understand so that when this happens, because as Dr. Johansson said, there's going to be a background level. Just based on probability, there's going to be a background level of school age youth in our county that are going to get COVID, not necessarily in a school setting. So we've been working with the schools to try to understand some of that, to recalibrate this notion that one case means a shutdown, because that is not the case. So while I would love to say, yes, there will be standardization and every school district will act the same, I'm not 100% sure, and each school district and private school is really under their own set of pressure and stakeholders, and they're going to have to make decisions that are best for their students and families and staff. And similar to how the schools really want a one-size-fits-all plan for the health department, COVID-19 investigations just do not lend themselves to one-size-fits-all response plans. So there might be an instance where having X number of students in a school warrants, okay, maybe we should move to virtual for 2 weeks to break this chain of transmission. Whereas that same number of students, given different circumstances and how those students are connected or not connected and what's going on in the schools and the school's ability to maintain the integrity of the educational environment, that could have a different result, even though the number of cases is the same. It's the timing, it's the epi links, it's can the school function? Because as much as we want science and data alone to drive this, we absolutely have social and political factors that need to be taken into account for every response decision. And that is going to look different throughout the county. So the thing that is standardized is that all schools know exactly how to work with the health department. We have processes in place that we've used over the last month in school related things. I mean, we got 90 minutes into the school year before we had our first phone call from a superintendent saying, what do we do in this situation? And so we were able to walk them through. We've had athletes that came back positive and their test result came back while they were at practice. So we have walked with the schools through those procedures already, and all of that is working well from our end. We've gotten good feedback from the schools we have worked with hands-on. It's going well on our end. So that is what we can promise is standardized, that we will be walking through the same sort of process. The outcomes will look different because there is variability in every single investigation, and knowing how important education is and how long lasting this response is. It's really important that if we can find ways to maximize in-person instruction for the families that have opted into in-person instruction, and not have that knee-jerk reaction to, we can't do this, let's just close. We're working to maximize in-person instruction.
Agree with that.
Yeah, Linda.
And mind you, I'm not saying that this is our responsibility. So, but where are the supports for the parents? I mean, you have a parent who has said, my child can go back to school, is going back to school. The child tests positive. The parent has no sick time. It seems to me that perhaps there might be some recommendation by the health department. I think this would be within the bounds of advocating that businesses have separate sick and vacation time, so that there is adequate time for parents to be able to take care of their kids, to be able to take care of themselves if they're sick and not have to go to work. I mean, I was disappointed that our elected officials didn't do something like that when we were closed down, but instead chose to sue the governor. I thought that was a lost opportunity where they could have really had an impact, but that's not how they chose to do it.
So all I can say is that we have the health department in some of our materials that we've put out there for businesses is we've put information out there for businesses to consider. There are a lot of employers that do have sick leave policies that are more helpful. And there's some that have ones that are less helpful in terms of dealing with some of the issues of isolation and quarantine that come up. There are some safeguards in place from federal programs. There are things, I think we're seeing a lot of flexibility as the health department. We're putting information out of if you have this type of policy in place, here's what the impact could be.
Okay, good. Thank you.
Yeah, Dr. McBride.
Where's the state of vaccines? What will be our role in administrating them? Are we prepared for that?
Yeah, so excellent. And yes, we are preparing for that. So Dr. J, do you want to talk a little bit about COVID? And I think this would be a good time to also talk about flu vaccine as well. So Dr. J, talk about COVID vaccine, please.
So the COVID vaccines, as you know, the Russians supposedly have one that's about ready, and the Chinese also have another one that they're giving to their military now after they've done some trials. So both of those two vaccines are based on, it's tied in with adenovirus, another virus adenovirus 5, which has been used as a vehicle for other vaccines and vaccine attempts in the past. Some problems with that vaccine is, others have pointed out, and that I see with it is, about 40% of the American population has an immunity to adenovirus 5, so they may reject it right away because they've already encountered this virus, so wouldn't even have a chance to work because we're rejecting it. And in some parts of the world, like in Africa, 80 to 85% of people have antibodies to adenovirus 5, so it really wouldn't work there at all. So that's a problem with it. And also, since a lot of us have immunity to it, there's a really high chance that a lot of people would have a fever and a reaction to it, which of course would not be a good thing for the rollout of any vaccine at all. So those two adenovirus 5 ones are problematic. I'll still stick with the Moderna one that I've talked about before, which is the one based on messenger RNA. It's like a hepatitis B vaccine, a very small amount of antigenic material. Virtually nobody has any side effects to that vaccine. And the few who do it probably isn't related to the probably isn't a vaccine side effect. So that's the one I'm hoping for. That could happen this year. I think that is an achievable goal, in part because they're using volunteers now who are actually taking the virus in to see if the vaccine works. And these people are doing that voluntarily. And the list of people signing up to do it is amazingly long. So that's one, that type of vaccine is the one that I'm most excited about it, because when we roll this out, we really want to have limited side effects. So
And so this,
the vaccine.
yeah, thank you. Sorry to, in terms of the distribution of a COVID vaccine, mass vaccination is something that is somewhat the bread and butter of public health, local health departments. We have a lot of experience with this. We did it in a very large scale 11 years ago with the 2009 H1N1 vaccine. We have very small dry runs of that every year with influenza vaccine. So we have definitely pulled off our max vaccination plan off the shelf. We started dusting that off in March, knowing that we would need it at some point during this course. The state has been doing the same. So there is a lot of state and local planning. Some of the approach that we're taking is we know that influenza vaccination is incredibly important this year, just to help. It's going to become a very confusing environment when we have more respiratory viruses circulating, and therefore we have more people with symptoms. It's going to be a lot harder to suss out who's got what and who needs to be isolated for what period of time in the absence of testing. So flu vaccine is always a good idea. It's a very good idea this year. And we know we have people who are hospitalized every year due to complications from influenza, and we don't want that added strain on our healthcare system here locally, as a state, as a country as well. So really important for flu vaccination. Courtney has been helping to lead the efforts just to make sure, because our flu vaccination season this year is going to look a little different than it did last year. We're trying to use it as dry run for COVID-19. And it's just harder to gather people in large quantities to get them vaccinated with everything, all the measures that we need to be in place. So I don't know, Courtney, if you want to talk a little bit more about what we've got very loosely. I mean, there's still a lot that's being shaped, but.
Sure, absolutely. So just really high level, because we are still working on a lot of this, but as Nikki said, we really want to make sure that we are having large scale access to the flu vaccination this year. And along those same lines of COVID, we want to really focus on our vulnerable population. So our older adults, those with other underlying health conditions, any of our Black and Brown residents, we want to make sure that our minorities are really covered as well. We want to work with partners. Some of this is the health department actually doing the vaccination. Some of this is assurance and just working with our partners to make sure that we're getting into a lot of different pockets of our community. So what we've been doing over the last week or so is really thinking through, where do we need to be maybe doing some satellite clinics or some pop-up community clinics this year? So that's where some of that, it's going to look a little bit different maybe for the health department this fall. That also is an opportunity to test some of our practices around vaccination that we can then scale up once we get to having a COVID vaccination. So there's some dual benefit to that. But our intention is to do, of course, more hours in our own offices. So in Benton Harbor and Niles, as well as in our Three Oaks office, to do a lot more partnership across our program. So if someone comes in for WIC or sexual health, making sure that we're having that flu conversation and doing that right then and there when someone's already here in our office. Working with Spectrum Health Lakeland again to get into some of our senior housing complexes. We tend to divide that up between our two entities and get into those complexes and go on site. And then talking about how are we reaching out to our shelters and jail, as well as then just some of those strategically placed pop-up areas. So really thinking about where in the Benton Harbor area can we do that, where in the Niles area, and then kind of the Harbor Country area as well. Especially in that Harbor Country area, we know there are less pharmacies. So we have also been following up with all of our pharmacies to say who's doing flu vaccination, what ages, what times, what does that look like? Can definitely get more of that information out. A big piece of this will be communication and outreach, but so far we have heard from our pharmacies, they are all doing flu like normal. They're going to have stock, they're going to do that. So we're trying to find the pockets of area where that might not be a good coverage, or where someone might not get to one of our offices or get touched by Intercare or Niles Family Health Center. So I guess the wrap up of that is know that that is in the works. Our plan is to be able to be operationalizing all of that in October, November, and December. So there'll definitely be some good push in October. Some of it will be early November, and that's more of an insurance that we have all of our vaccination stock in, because that kind of trickles in over the next 6 to 8 weeks. One thing to note with that is we are receiving some funding this year from the state of Michigan. So Michigan Department of Health and Human Services has notified us of 2 different pots of funding that will be specific for flu vaccination. One will be for kind of this last quarter of 2020. So we'll have to use that funding between October and December. And then the other will help carry us through kind of the beginning of next year. And so that will allow us to do some of that more strategic communication and outreach to get some of those supplies we need for these pop-up community sites, because there are some logistical things that go into that of having to transport vaccination and staff time as well. We'll be having to do some redistribution of staff to help with some of those events. So that's all factors that we're talking through and working through, as potentially some time for nursing staff. So we will certainly need a few extra hands to give all of those vaccinations. So I think that's kind of where we're at for now. We'll definitely have more thorough information, and I think could share with you some dates and different things by the time we have our October meeting. But we're putting a lot of strategic thought and partnership around what that will look like this fall for Berrien.
Thank you.
Courtney, how
Sounds
much
like
do you
you're
think
ready.
that funding is going to be?
I'm sorry, I missed
How
that.
much do you think that funding is going to be?
I think, and Nikki, please top it. I know that the first part for the fall, I think, is 65,000. And then it might be the same for then the next. So I think it's like 130, 35 overall. Is that about accurate?
Yeah, so the half of that must be spent by the end of the year,
Yes.
which will be fine because that's when a
Sure.
lot of the vaccination, and then the remainder by I don't remember if it's the whole fiscal year or if it's in next summer or spring, but about 130,000. So that will be coming through the comprehensive agreement and a resolution to accept that funding sometime soon.
Okay, great, thanks.
Be more money for Lisa to juggle, huh?
There you go. Keep her busy.
All right.
There are 2 more things I want to mention related to COVID. The state is going to be announcing, we hear sometime this week, they will be announcing a series of neighborhood testing sites. So these are pop-up, well, not quite pop-up, but long-term temporary locations in various communities throughout the state of Michigan. There are 22 planned in the state. And we are the only county that is receiving 2 of those neighborhood testing sites. So there is one planned for the Niles area, and there is one planned for the Benton Harbor area. So more details about those will be coming out. These have been in the works since probably May, it feels like. So there's definitely been a lot. There's been some issues with the vendors, but the state is the one that will be handling. There's going to be a vendor that comes in. So that's not anything we're involved in. And there's some community partners that are involved in some of the outreach, but definitely will be continue to be part of outreach. So You may hear an announcement this week about those additional test sites. And then I did want Jillian to give us a very quick update about the new positions that were approved this past month or in August for COVID-19 response that came with that funding from the state.
Yes, thank you, Nikki. Very, very quick. As you remember, there were 9 new positions that were approved by you as well as the Board of Commissioners, and we are moving as quickly as we can to gather those applications, start the interview process, and I'm very pleased to report that we are making great headway with all of the positions, the contact tracers, the case investigation, our project coordinators, as well as a communications specialist. All are in some interview phase, whether it's first interview, second interviews, and there's a few that we're almost ready to make offers on. So very good news for that. And we are hoping to have the majority of those people hired in and well underway with orientation before the end of the month.
Wow. Great.
Yeah.
Thanks, Bill, for your role in the county board. So appreciate it.
Thank you.
Question, if I may. I know we struggle to get staff sometimes. Is our ability to, what do you attribute our ability to attract so many people who seem to be qualified for these positions?
So,
Oh.
Jillian, you want to go ahead?
Well, you might have something else to say, Nikki,
Well,
but I am just thinking, you know, over the last several months, there has been a extreme renewed interest in public health. And we have just seen a lot of really qualified candidates. I'll tell you the folks that I'm looking at for the communication specialist position don't necessarily have a strict public health background, but said, you know, over the last several months, we saw what local health departments do. We understand the importance of this field and we want to be part of it. So I think that there is just that interest overall that we're attracting really great candidates. Nikki, you might have something different to say.
Yeah, and I would say on the other side, and we've seen this trend over the last few years, at least from my perspective, is that when we've had positions for people who can do some public health work, but there's not a special credential required, it's a little bit more of a generalist. We've had a lot of really good applicants. It's when we're looking for nurses or some other type of certification and a type of employee that could also work in other fields. That's where we have struggled a little bit more. But there are just more public health programs at the both undergraduate and graduate level, and it's becoming a much more common degree even than when I got my MPH 11, 12 years ago. The educational landscape has just changed and it's on more people's radar. And there are people out there who have those public health degrees, but no other special credential. And they just want to do public health work. And this is the first time we've had many of those positions available all at the same time. And I think that's why we're getting good applications. And I think that's intelligence that we need to figure out how to take forward as we're figuring out what does the health department of the future look like. I know we have 2 more things on the agenda that I think we can get through very quickly. Just wanted to mention something about EEE because this is that time of year. As you may recall, this time last year, we had multiple animals as well as human cases of EEE in Berrien County. There were multiple human cases across the state by this time last year. There has been a little bit of EEE activity. There have been somewhere between 8 and 10 horses throughout the state that have tested positive. I believe they've all been unvaccinated horses as well. The closest confirmed animal case that there has been to Berrien has been Kent County. So not quite way far away, but still not right in our backyard. We're continuing to encourage folks to do what they can to prevent mosquito bites and to be particularly mindful as they're taking what may have been indoor activities outdoors and trying to really sneak in more outdoor stuff this fall. That even in a time of COVID, we still need to fight the bite, but just wanted to make sure you are aware that that is being monitored. That is something that surveillance of vector-borne illnesses is something that we're definitely watching. And I think at a state level, want to make sure that resources still exist to do that, even when lots of things are being diverted to COVID. So that's an ongoing advocacy effort. And then Courtney, did you want to mention anything about the ale quickly? Nope, you're on mute.
Sorry.
Yeah.
All right, real quick. I think that we talked earlier this summer just about the continuation of doing the water sampling every 6 months. So, and then that had continued. I think the only new update that it would be helpful right now is we are continuing to do all of our water filter distribution activities and have been working with a lot of community partners to ensure that residents know that's happening, just because there have been so many disruptions and changes with COVID. And so what that looks like is, again, we are mailing, we have a hotline and people can call, and we are getting filter replacements in the mail. We are still having a lot of pickups here, and we have those packaged and ready and can do that quick pickup, as well as we've been able to reestablish, we've had one all summer, but we've been able to kind of ramp up just a little bit more and have 2 a month now of the drive-through pickup events in the city of Benton Harbor. So just trying to keep that access and that awareness there. The other piece is you will see throughout the fall, if you receive or read the Benton Spirit, there has been a community partnership between some local community residents, the city of Benton Harbor, Eagle, MDHHS, and the health department to just meet and talk collaboratively around just awareness and education around water activities in general for residents. And so there will be a 3-part series in partnership with the Benton Spirit coming up. I think the first one is in September, October, might be 2 in October, November, not quite sure the timeline, but I will send that out. So just wanted you to be all aware of that. It's going to kind of walk through some of the history of the water plant itself and things that have happened there, through the timeline of the original action level exceedance, some of the resources that are available. And again, really to help build that awareness of where the lead is coming from in water, and talking about those lead service lines and that housing infrastructure, as well as then what's being done to solve that problem. So some more in-depth information, of course, about water filters, but more about that corrosion control activity, and then some city initiatives that are happening around trying to acquire additional funding to actually do the service line replacement. So that's all still happening and moving forward as well.
Thank you. It's amazing to have that moving too. Okay. Bill, do you have anything for the good of the group?
I'm sure it's not for the good of the group, but we are entering the always fun budgetary season, and you've just gotten a taste in a very good presentation. I think we've got 14 or 15 different and do that kind of torture chamber with us. So we're looking forward to having everything go smoothly in this era when we don't know what's going on.
Any questions for Bill?
When do you leave? I mean.
You're counting the days, Vanessa.
No, I don't. I want you to go. You've just been great. You've been such an asset, and such a great communication between the board and us. And we're really gonna miss you.
I appreciate that. Thank you very much. My term runs through the end of the year.
Okay.
So even though we will have an election in November, I'm not going out until December 31st.
Okay.
So I'll be around.
Okay.
Right. Thanks, Bill. So we have a reminder of the voting on board positions. So voting for Kim to be secretary. If there's any movement you want to make, anyone dying to be president, vice president, or anything like that, would you let Nikki and me know? So if you would like to do any shifting, let us know. So
No, no shifting.
no, no. So, well, I want to make sure where Joe and I aren't clogging up things if you want us to move on. So, I mean, I should speak for myself rather than Joe. So, all right. Anything else before we adjourn?
Peg, I do think that there is a public comment from somebody on YouTube.
Oh,
So
okay.
Jillian, could you handle that for us, or?
Yes, one comment, and it comes from our county administrator, Brian Dissett, and he says, Lisa, nice work on your presentation. This was helpful for me to learn about your department and budget.
All right,
Wow,
thank you.
that's good.
Good comment.
Yeah. All right. Well, thank you all. We'll see you in October. We do not have a board prep meeting in September. So thanks for the great job by the staff and good comments by the board. Thank you.
Yeah. Thank you
Good
all for your
meeting.
support.
Thank you all.
Everybody.
Bye.
Bye.